what do you know or have to say about cardiac bypass artery graft, CABG surgery? What does the evidence say about this? What is the information? What do you have to tell us about this?
Coronary artery bypass grafting is a fairly major surgical procedure to try and improve the blood supply to the heart. And so it's for arterial disease in the heart. It was a boom industry in the 80s and 90s and has suffered greatly because of the interventionalists, and now most patients have stents. And so stents are done for the same thing. They're done to unblock narrowings in the arteries that feed the heart. That actually, it's hard to understand. People don't see how the heart needs blood because it's full of blood, but it actually needs its own blood supply. And that's the problem. And that's what causes a heart attack if that gets blocked. Unfortunately, though, the larger high quality studies where people have had this procedure compared to, just taking drugs or other medical treatments or not having it done at all, have shown that for what we call stable angina, which is not somebody having a heart attack right now, but somebody with heart disease, that having this procedure is not better than not having it, all the alternatives. And having a stent for a stable angina or just heart disease that's visible on a scan is the most common reason for having it done. So it's one of the most common surgical procedures performed. It's very common, with hundreds of thousands have been done. And there is some evidence for it in acute situations, but for most of the time, it's not better than not having it. And again, it's hard to get that message across because it makes sense, but you're narrowing a tight artery, that must be better. But there's other things that happen when you do that. There's unintended consequences. The heart develops other blood supplies to make up for that narrowing. There's all these sort of complicated issues that go into it. But there's been some high quality studies showing that it's not better than medical or non-surgical alternatives.
Let me see if I can clarify what Dr. Harris said. And he traipsed onto stents and angioplasties in a question that was regarding coronary artery bypass grafting. And I think it might have been a little bit confusing for the audience, but he gave a good answer. But I'll see if I can describe the literature. And I'd love to hear criticisms of what I'm saying and see if what I've read is correct. For coronary artery bypass grafting, the only successful prolongation of life, the only improvement in mortality is in the left main disease, right? It's a 2-centimeter piece of artery that connects up two other major arteries that surround the heart. Now, if you plumb your way around that, and that's what coronary artery bypass grafting is, it's a simple conceptually, and it makes sense in a certain kind of a way, but the only studies that have shown improvement in lifespan have been in plumbing around the left main artery, not in any of the other arteries, right? So these guys, these surgeons, conceptually, it seems to make sense. They plumb their way around. The people have coronary blockages in multiple places. They do 5, 6, plumb arounds, and they see improvement in the way the heart looks in the chest. But the only improvement in mortality, in lifespan, is this plumbing around the left main. The left main equivalent, which is plumbing all 3 of the arteries simultaneously, does not produce an improvement in mortality, right? And the improvement in mortality is only 20% at 5 years. I mean, let's see if I remember exactly, but let me see if I remember. It's a small improvement in mortality for this one specific instance. And the entire edifice of coronary artery bypass grafting, the surgery, stands upon this one bit of evidence that only applies to left main disease, right? Now, traipsing onto the other subject, which is the competing industry, which is angioplasty. These guys have proven with their studies, the cardiologists, that the only time that they make an improvement in mortality, which is all you really care about, is if you have an acute event. You're really sick, you've got chest pain, and you're in trouble. You have what's called an ST elevation myocardial infarction, which is an obvious sign in the EKG, and it's actually relatively rare in terms of heart attacks. Dr. Harris said it properly, and he made the point correctly, that 95% plus of the angioplasty is done in disease which is chronic. They may not even have chest pain, but they go into the doctor's office, they get a stress test, and then they get angiogrammed, and they find these lesions, and they're not symptomatic. And 95% plus of angioplasties and stents are done on people without chest pain at all, right? And so they supposedly they can get a big improvement in the people with chest pain. But frankly, I looked at the numbers and I analyzed it in my book, and I think the entire effort is unfounded. And my reference is Norton Hadler's work. And he runs over the numbers, and I looked at them all, and I think that basically angioplasties are next to useless, and stents are absolutely without foundation. They got these drug eluting or drug secreting stents, and it just doesn't improve mortality, which is all you care about. And the only instance where it supposedly works are a small percent of the heart attacks where they have ST segment elevation. They're very sick, and these people they take them to the cath lab and they die in the cath lab in some percentage way that mimics the the whole thing is a crazy effort. And I think these industries should be discredited. We spend about the same on coronary artery bypass grafting as angioplasty and stenting now. And, they pass them back and forth. One doesn't work, the other, they pass them the surgeon or the cardiologist. I'm curious about what Dr. Abrams has to say about what I just said, because I know he knows these numbers.
Yeah. Excuse me. I agree. I think there's a wonderful natural experiment that has happened. Ontario, Canada, controls the number of facilities that can do cardiopulmonary bypass surgery, coronary bypass surgery. And so in Ontario, there's 1/5 the number of facilities that do the procedure as there are in Pennsylvania, which has the same population. So in Ontario, the doctors have to decide which 1/5 of the patients are going to get the bypass surgery, and Pennsylvania has an open door. What they found is that there's absolutely no mortality difference between Pennsylvania and Ontario after an MI. What it shows is, at the very least, that the doctors in Canada can figure out which 1/5 of the 20% of the patients who are having an MI deserve coronary bypass surgery compared to the people in Pennsylvania. And it goes back to this idea that we have a market-based medical system. You can make money if your hospital does bypass surgery. There's no question about that. But we're not making people better in proportion to the amount of money that's being spent on it. Plus, it's very important to remember that it's major surgery, and a significant portion of folks, in proportion to their age, have mental status changes after their bypass surgery. So it's not without medical costs either.
3 to 9% of them die, and 30% of them have brain fog that lasts months. It's measurable neurological deficits.
Right.